Artificial intelligence is reshaping point-of-care ultrasound and echocardiography by making examinations faster, more standardised, and more reliable at the bedside. Today, modern systems can support the operator in real time rather than relying solely on manual optimization and manual tracing. AI can help guide probe positioning and view acquisition, and it can continuously optimize image settings as you scan. It can also automate key measurements and streamline quantification, improving consistency and efficiency. This matters because echocardiography is highly sensitive to technique, and variability in acquisition and analysis can change results between clinicians and settings. In this module, we will focus on how AI supports guidance, quantification, and clinical decision support in everyday echo practice. We will also consider limitations, governance, and why clinical judgment remains essential. A practical way to understand AI in ultrasound is to break it down into core domains of support. First, acquisition guidance helps the operator obtain the right view by prompting probe position and orientation. Second, image optimization can automatically adjust settings such as gain, depth, and focus to improve visualization. Third, measurement automation can identify structures, track motion, and generate repeatable quantitative outputs. Finally, diagnostic support sits closer to clinical interpretation by suggesting patterns or probabilities that may inform decisions. Across all four domains, the goal is greater consistency, reduced operator dependence, and faster workflows at the bedside. The first domain is acquisition guidance. The aim is to help the operator obtain the right window, the right plane, and the correct probe orientation in real time. AI can recognize when you are close to a standard view and provide simple prompts to adjust position, angulation, or rotation. Many systems also provide a quality score, so you know when the image is adequate for interpretation and measurement. In practice, this functions like a virtual tutor that gives immediate, constructive feedback during scanning. This is particularly valuable when supervision is intermittent or unavailable. It lowers the entry barrier to competent scanning while reinforcing good technique. Over time, it helps users move from finding any image to reliably acquiring standard, repeatable views. Here is another example of AI acquisition guidance in practice. The software recognizes the intended target view and displays a reference image alongside the live scan. It then provides simple, real-time instructions to adjust probe position, rotation, and tilt until the view aligns. Some platforms also recommend practical settings, such as depth to support rapid optimization at the bedside. Once an adequate quality threshold is reached, the system can prompt you to record a loop for interpretation and measurements. Here is one more example of acquisition guidance integrated into a portable ultrasound workflow. The interface combines a body map with a target view preview, so the operator knows exactly what to aim for. As you scan, the system provides live coaching cues to adjust probe position, rotation, and angulation. This helps you converge on a standard view more quickly. Once the view quality is sufficient, you can capture a loop with greater confidence in reproducibility. The second domain is image optimization. This is sometimes less visible to learners because the result is simply a cleaner, more readable image. In practice, it is central to reliability because it reduces dependence on constant manual adjustments. AI can adapt key parameters in real time based on the detected tissue and scene characteristics. This includes continuous optimization of gain, dynamic range, speckle reduction, and contrast. Some systems also harmonize settings across devices and users, so images are more comparable between shifts and sites. In addition, a quality indicator can help confirm whether the view is adequate for measurement or interpretation. Used well, optimization improves consistency without replacing the clinician's responsibility for image adequacy. In vascular and cardiac applications, AI can also optimize color Doppler in real time. It can automatically tune parameters such as velocity scale, gain, and wall filters to stabilize the flow display. This is particularly helpful in technically difficult conditions where noise and artifact can dominate. Some systems include automatic flow optimization that guides acquisition rather than post-processing. By supporting probe orientation and inclination angle, Doppler signals can be obtained more consistently. The practical result is that hemodynamic measurements become more robust and less dependent on meticulous manual knob turning. The third domain is measurement automation. Instead of manually tracing contours and repeating measurements across systole and diastole, AI can propose borders and compute volumes automatically. This delivers faster, more reproducible estimates of clinically meaningful parameters. Many clinicians feel the operational impact here first because it directly compresses workflow time. It also reduces inter-operator variability by standardizing how measurements are derived from the image. A simple example is automated bladder volume measurement. The system detects bladder contours and provides a rapid estimate that can support assessment of urinary retention. In echocardiography, measurement automation often means the system can identify key structures and place calipers for you. Typical examples include left ventricular dimensions and aortic root or ascending aorta diameters. By standardizing where and how measurements are taken, AI can reduce variability between operators and between sessions. It can also speed up routine quantification, which is valuable when time is limited. Measurement automation also extends to Doppler acquisition and analysis. Auto-Doppler can place the pulsed wave Doppler sample volume in standard locations, such as the left ventricular outflow tract and across the mitral, pulmonary, and tricuspid valves. For tissue Doppler, the system can position the sample at the mitral septal and lateral annulus and at the tricuspid annulus. Some platforms also adjust the baseline automatically to optimize the spectral signal display. This reduces repetitive manual steps and improves consistency between operators and across studies. You still need to confirm signal quality, avoid artifact and aliasing, and ensure the interrogation is clinically appropriate for the question being asked. A key example of measurement automation in echocardiography is automated left ventricular ejection fraction. Using standard apical views, the software detects and tracks the endocardial border across the cardiac cycle. It can then derive biplane volumes and report EF alongside EDV, ESV, and sometimes stroke volume. The benefit is a rapid and reproducible assessment of systolic function with less manual contouring. Performance still depends on image quality, correct plane selection, and avoiding LV foreshortening. Arrhythmia and marked regional wall motion abnormalities can also challenge automated tracking. You should always review the proposed contours, adjust where needed, and confirm the end systolic and end diastolic frames. Used carefully, automated EF supports efficient reporting and more reliable follow-up comparisons. Another practical example is automated measurement of the inferior vena cava collapsibility index. The software identifies the IVC in a suitable subcostal view and tracks its diameter over the respiratory cycle. It then calculates the collapsibility index from the maximum and minimum diameters with less manual caliper work. This can improve consistency between users and speed up serial assessments at the bedside. The fourth domain is diagnostic support, and it should be clearly distinguished from measurement automation. Here, the goal is to assist clinical decision-making by recognizing structures, detecting patterns, and flagging findings that may warrant action. This can support screening, triage, and risk stratification, sometimes without an explicit step-by-step chain of measurements. It is also the most regulated and most sensitive area because small errors can translate into incorrect diagnoses. For teaching purposes, it is important to treat diagnostic output as a suggestion rather than a conclusion. Every AI output should be handled as a hypothesis that you check against image quality, clinical context, and overall plausibility. The clinician remains accountable for the final interpretation and the decision that follows. In lung ultrasound, diagnostic support often focuses on recognizing repeatable artifacts and patterns. AI can detect A lines and B lines, and it may also identify features suggestive of pleural effusion. Some systems extend this to patterns consistent with consolidation or atelectasis, depending on the use case and regulatory scope. This can be useful for standardization, training, and rapid bedside triage. However, artifacts can be confounded by probe position, gain, body habitus, and underlying chronic lung disease. You should treat the AI output as decision support and always confirm it against image quality and the clinical picture. In the example shown here, the software highlights A lines and rib shadows to support a structured interpretation. Artificial intelligence is increasingly used to detect vertical artifacts, such as B-lines during lung ultrasound. The operator scans the patient using a standard set of anatomical zones. The system can automatically assign each clip to the correct zone to support structured acquisition. It then detects the pleural line and rib shadows to anchor interpretation. B-lines are identified in the selected zone and automatically counted. Some solutions also estimate spacing between B-lines as a proxy for severity. The software can calculate the proportion of the scanned area affected by B-lines and display it as a percentage. This helps standardize reporting and make serial comparisons more consistent. Once you frame AI in domains, choosing an ultrasound system becomes less about marketing labels and more about fit for purpose. If your priority is scaling echocardiography competence across a team, acquisition guidance and view standardization can deliver immediate training value. If your priority is throughput and consistent reporting, measurement automation and workflow integration become key differentiators. If your priority is bedside reliability in challenging patients, robust real-time image optimization and stable Doppler performance may matter more than an extra automated metric. It is also important to consider how future-proof the platform is. AI capabilities evolve rapidly, so review the device's update pathway, the manufacturer's track record for software upgrades, and the governance model for deploying new algorithms safely. Finally, do not overlook operational details such as battery life, energy management, data transfer, and ease of cleaning, because these can determine real-world usability in point-of-care practice. In summary, AI in ultrasound is not one feature, but a set of capabilities that support different parts of the workflow. It can guide acquisition, optimize image quality, automate quantification, and in some cases support diagnostic reasoning. The educational opportunity is to help clinicians use these tools to improve speed, reproducibility, and standardization. At the same time, a disciplined approach to verification is essential because clinical responsibility does not transfer to the algorithm. Over the last decade, miniaturization and falling costs have expanded access to ultrasound at the point of care. AI now has the potential to help ensure that broader access translates into consistently high-quality examinations, including when operators are less experienced. The most successful implementations will be those that match capabilities to clinical needs, measure performance, and maintain robust governance.